Hello there. Now let's move ahead with another and a new scenario in rheumatology. So here we have a 65-year-old man who has a generalized rash, fever, joint pain, muscle pain. His medical history is significant for a late onset asthma associated with nasal polyps. He recently has been diagnosed with heart failure and eosinophilia was shown in his last blood test. Chest x-ray shows fleeting peripheral pulmonary infiltrates and bilateral multifocal consolidations. So what is a single most likely positive antibody in this case? So the diagnosis here is Churg-Strauss syndrome, and this Churg-Strauss syndrome is now commonly known as eosinophilic granulomatosis with polyangiitis, that is EGPA. Churg-Strauss syndrome and EGPA both are same. EGPA is eosinophilic granulomatosis with polyangiitis, or it is also called as allergic granulomatosis. Eosinophilic granulomatosis with polyangiitis or allergic granulomatosis. That is Churg-Strauss syndrome. 30 to 40% of these patients are PANCA positive. That is PANCA positive. That is PANCA positive, which is perinuclear staining. So 30 to 40% of these patients of Churg-Strauss syndrome or eosinophilic granulomatosis with polyangiitis, that is EGPA, or allergic granulomatosis, these are PANCA positive or perinuclear staining positive. Let's study a little more about Churg-Strauss syndrome now. So Churg-Strauss syndrome, it is a rare diffuse vasculitic disease affecting coronary, pulmonary, cerebral, abdominal, visceral, and skin circulations. The vasculitis affects small and medium-sized arteries and veins, and it is associated with asthma. The cardinal manifestations of Churg-Strauss syndrome are asthma, eosinophilia, and lung involvement. That is, these are the cardinal manifestations of Churg-Strauss syndrome: asthma, eosinophilia, and lung involvement. So again, it is a rare diffuse vasculitic disease leading to vasculitis. So rare diffuse vasculitis disease affecting coronary, cerebral, pulmonary, abdominal, visceral, and skin circulations. The vasculitis is affecting small and medium sized arteries and veins, and it is associated with asthma. The cardinal manifestations of Churg-Strauss syndrome include asthma, eosinophilia, and lung involvement. Now, the incidence of Churg-Strauss syndrome is rare. Therefore, it is also rarely asked in exams like Plab. However, one might see this topic every now and then. Okay, the American College of Rheumatology has identified 6 criteria for the diagnosis of Churg-Strauss syndrome. Now, what are these 6 criteria? First is asthma, that involves wheezing, expiratory bronchi. Second is eosinophilia of more than 10% in peripheral blood. Third is paranasal sinusitis. Fourth, pulmonary infiltrates, which may be transient. Then, fifth, histological confirmation of vasculitis with extravascular eosinophils. Sixth, mononeuritis complex or polyneuropathy. Mononeuritis complex or polyneuropathy. So these are the 6 criteria given by American College of Rheumatology, which are used for the diagnosis of Churg-Strauss syndrome. First is asthma, second eosinophilia, third paranasal sinusitis, fourth pulmonary infiltrates, fifth histological confirmation of vasculitis with extravascular eosinophils, sixth mononeuritis multiplex or polyneuropathy. Mononeuritis, multiplex, or polyneuropathy. So these are the 6 criteria. The presence of 4 out of 6 of these criterias or features have high specificity and sensitivity for the diagnosis of Churg-Strauss syndrome. Okay, so now talking about presentation. The most prominent signs and symptoms. Talking about presentation of Churg-Strauss syndrome. First, pulmonary. It will include asthma, then upper respiratory tract, which includes allergic rhinitis, paranasal sinusitis, nasal polyposis. Cardiac involvement includes heart failure, myocarditis, and myocardial infarction. Skin includes purpura and skin nodules. And renal presentation involves glomerulonephritis, and last is peripheral neuropathy. So the most prominent signs and symptoms in Churg-Strauss syndrome, there will be first pulmonary involves asthma, upper respiratory tract, allergic rhinitis, paranasal sinusitis, and nasal polyposis. Cardiac features will be cardiac involvements, which is very common. It will include heart failure, myocarditis, and myocardial infarction. Skin will involve purpura and skin nodules. Then kidney or renal system, it will include glomerulonephritis. Then last, peripheral neuropathy. This is the presentation. Now talking about investigations. First, anti-neutrophil cytoplasmic antibodies. Anti-neutrophil cytoplasmic antibodies, that is ANCAs. 30 to 40% of patients are PANCA positive, that is perinuclear staining anti-neutrophil cytoplasmic antibodies positive. These are anti-myeloperoxidase antibodies. So these PANCA, these are perinuclear staining, and ANCA stands for anti-neutrophil cytoplasmic antibodies. These are anti-myeloperoxidase antibodies. 30 to 40% of the patients are positive, PANCA positive. Second, eosinophilia and anemia on full blood count. Then elevated ESR and CRP. Then increased levels of serum IgE, increased serum IgE levels. Then chest X-ray may show pulmonary opacities, transient pulmonary infiltrates, and bilateral multifocal consolidation. So chest X-ray will show pulmonary opacities, pulmonary infiltration, bilateral multifocal consolidation. High resolution CT scan will show ground glass attenuation. Now biopsy, it will show small necrotizing granulomas as well as necrotizing vasculitis found spatially in the lung. So again, anti-neutrophil cytoplasmic antibodies, these are PANCA. PANCA is in 30 to 40% of the patients of Churg-Strauss syndrome, PANCA is positive. And okay, let's Talking about investigations, first, PANCs are positive in 30 to 40% of the patients. This PANCs, these are anti-neutrophil cytoplasmic antibodies. So P stands for perinuclear staining, which is positive, and these are also called as anti-myeloperoxidase antibodies. Now, another point in investigations are elevated ESR and CRP level, and eosinophilia, anemia on full blood count, then increased serum Ig levels. Chest X-ray will show pulmonary infiltrates, pulmonary opacities, and consolidation. High resolution CT scan will show ground glass attenuation. Biopsy will show small necrotizing granulomas as well as necrotizing vasculitis. Small necrotizing granulomas as well as necrotizing vasculitis, which is found spatially in the lung. So this is about Churg-Strauss syndrome. Again, it is a rare diffuse vasculitis disease affecting coronary, pulmonary, cerebral, abdominal, visceral, and skin circulations. Vasculitis mainly affects small This vasculitis mainly affects small and medium-sized arteries and veins and is associated with asthma. The cardinal manifestations of Churg-Strauss syndrome includes asthma, eosinophilia, and lung involvement. Now, the American College of Rheumatology has given 6 criteria for the diagnosis of Churg-Strauss syndrome. These 6 criteria are: first, asthma; second, eosinophilia; third, paranasal sinusitis; fourth, pulmonary infiltrates; fifth, histological confirmation of vasculitis along with extravascular eosinophils, and basically it is vasculitis or histological confirmation of vasculitis. And sixth, polyneuropathy or mononeuritis multiplex or polyneuropathy. So asthma, eosinophilia, paranasal sinusitis, pulmonary infiltrates, vasculitis, and polyneuropathy. Presence of 4 out of these 6 features have got high specificity and sensitivity for the diagnosis of Churg-Strauss syndrome. Presentation: most prominent signs and symptoms: first, pulmonary asthma, then upper respiratory tract allergic rhinitis, paranasal sinusitis, nasal polyposis, cardiac involvement, heart failure, myocarditis, myocardial infarction, skin purpura and skin nodules. Skin will involve purpura and skin nodules. Then renal involvement, glomerulonephritis, and last, peripheral neuropathy. Pulmonary asthma, upper respiratory tract allergic rhinitis, paranasal sinusitis, nasal polyposis, cardiac, heart failure, myocarditis, myocardial infarction, skin purpura, skin nodules, renal glomerulonephritis, and peripheral neuropathy. For investigations, we have PANCA positive. These are perinuclear staining positive, that is anti-neutrophil cytoplasmic antibodies or anti-myeloperoxidase antibodies. In 30 to 40% of the patients with Churg-Strauss syndrome, these are positive. PNCs are positive. Then raised CRP and ESR level, and eosinophilia and anemia on full blood count. Then increased serum Ig levels. Chest X-ray will show pulmonary infiltrates, pulmonary opacities, and consolidation, bilateral consolidation. High resolution CT will show ground glass attenuation. Biopsy will show small necrotizing granulomas and as well as necrotizing vasculitis, especially in the lungs. So this is about Churg-Strauss syndrome. Let's go through the chart given here. So it clearly tells it is eosinophilic granulomatosis with polyangiitis. We already studied Churg-Strauss syndrome is also called as EGPA. That is eosinophilic granulomatosis with polyangiitis or allergic granulomatosis. Presentation is in the form of asthma, nasal polyps, purpura, glomerulonephritis. We studied already about presentation. in different parts: pulmonary, upper respiratory, cardiac, renal, skin, and peripheral neuropathy. So, presentation will include asthma, nasal polyps, purpura, and glomerulonephritis. Investigations: eosinophilia, PANCA positive, IgE levels will be high. Biopsy will show vasculitis with extravascular eosinophils. It can show necrotizing vasculitis as well as granulomas, as we studied. And for treatment, sorry, the mnemonic here, mnemonic will be PAVE, that is PANCA, asthma, vasculitis, and eosinophilia. We already know cardinal manifestation. These are uh, asthma, eosinophilia, and lung involvement. So we can remember this mnemonic PAVE for Churg-Strauss syndrome or eosinophilic granulomatosis with polyangiitis. PAVE stands for PANCA, which is positive, then A for asthma, V for vasculitis, and E for eosinophilia. For treatment, steroids. So, eosinophilic granulomatosis with polyangiitis, presentation asthma, nasal polyps, purpura, glomerulonephritis, investigations, eosinophilia, PNCA, increased Ig, biopsy, vasculitis with extravascular eosinophils. Mnemonic is PAVE, that is PANCA, asthma, vasculitis, eosinophilia. For treatment, steroids. Now let's move ahead. Now we have a 62-year-old lady presenting to the GP surgery with right-sided headache. Okay, so a 62-year-old presenting to the GP surgery with right-sided headache and decreased blurry vision over the past 2 days. She also has pain around her jaw, especially when chewing. Over the past 6 weeks, she has been feeling stiff over her neck, shoulders, and hips, especially in the morning. She struggles to get out of bed, out of her chair, as she feels her hips are stiff. On examination, there is tenderness over parts of her right scalp. Her blood pressure is 130/80. She has reduced power in the proximal muscles of her arms and legs. What is the single most appropriate initial investigation in this case? So they are asking about the single most appropriate initial investigation. Now, temporal arteritis, also known as giant cell arteritis, is a suspected diagnosis here. She also presents with symptoms of polymyalgia rheumatica, that is PMR, such as stiffness around her neck, shoulders, and hips. And there is also an association of giant cell arteritis filled with polymyalgia rheumatica. Some physicians believe that it is a single disease with slightly different presentations. ESR, erythrocyte sedimentation rate. This ESR test is the first test to do in patients suspected to have temporal arteritis or giant cell arteritis or even polymyalgia rheumatica. Now, since the question asked for the most appropriate initial investigation, the answer would be yes. If the question had asked for the most appropriate definitive investigation, then temporal artery biopsy would be the answer in that case. So again, here temporal arteritis or giant cell arteritis is a suspected diagnosis. She is also presenting with symptoms of polymyalgia rheumatica, PMR, that is stiffness around her neck, around shoulders and hips. This stiffness, it is referred to as polymyalgia rheumatica. And there is an association between temporal arteritis or giant cell arteritis with polymyalgia rheumatica. Some physicians even believe that it is a single disease with different presentations. Now, ESR, that is erythrocyte sedimentation rate, it is a first test to do so in these patients who are suspected to have temporal arteritis or giant cell arteritis or even polymyalgia rheumatica. Since this question is asking for the most appropriate initial investigation, then answer would be ESR. But if the question was asking about the most appropriate definitive investigation, then in that case, temporal artery biopsy would be the answer. Temporal artery biopsy would be the answer in that case, not ESR then. Initial ESR, definitive temporal artery biopsy for temporal arteritis, giant cell arteritis, or polymyalgia rheumatica. Let's study a little more about polymyalgia rheumatica and temporal arteritis separately. So first, temporal arteritis. Temporal arteritis, also known as giant cell arteritis, is a form of vasculitis affecting the large arteries which are supplying the eyes, optic nerves, and head. New onset headache in any patient older than 50 years prompts consideration of this diagnosis. The most feared complication of temporal arteritis is blindness, which can be easily prevented by early treatment with corticosteroids. So again, temporal arteritis, also called as giant cell arteritis, it is a type of vasculitis affecting the large arteries supplying the eyes, optic nerve, and head. New onset headache in any patient older than 50 years of age prompts consideration of this diagnosis. New onset headache in a patient more than 50 years of age. The most feared complication of temporal arteritis or giant cell arteritis is blindness, which can be easily prevented by early treatment of this by using corticosteroids. Now, the clinical features. Clinical features include headache on one or both temples, which is the most common feature, usually quick in onset, 1 to 2 days. Then scalp tenderness, which may be prescribed as pain while combing hair. Another is jaw claudication, and fourth one is decreased vision. So headache, scalp tenderness, jaw claudication, and decreased vision. The patient may have proximal stiffness of the neck, arms, hips, as polymyalgia rheumatica can coexist with temporal arteritis. So these patients may also have a stiffness around their neck, around their shoulders, arms, hips, because polymyalgia rheumatica can be associated with temporal arteritis, can coexist with temporal arteritis. Now, investigations. Initial investigation is ESR, erythrocyte sedimentation test, erythrocyte sedimentation rate. Definitive investigation is temporal artery biopsy, which shows characteristic giant cell. That's why it is called a giant cell arteritis. The treatment should not be delayed as it could result in permanent vision loss in the patient whom we suspect to have temporal arteritis. If the ESR is elevated, corticosteroid should be started as soon as possible before a temporal artery biopsy. So that is important so as to prevent a permanent vision loss in this patient, as Soon as we detect increased ESR in these patients where we are suspecting temporal arthritis, if it is elevated ESR, then corticosteroids should be started as soon as possible, even before going for a temporal artery biopsy. Now, prednisolone doses used in temporal arthritis are much higher than the doses used in polymyalgia rheumatica. Temporal arthritis, prednisone is 60 mg daily with gradual tapering. In polymyalgia rheumatica, prednisolone is given 15 mg daily with gradual tapering. So it is around 4 times the dose. So the dose of prednisolone, we already studied, treatment is with corticosteroids. In temporal arthritis, the dose of prednisolone is much higher than the dose in polymyalgia rheumatica. In temporal arthritis, prednisolone is given 60 mg daily with gradual tapering, whereas in polymyalgia rheumatica it is given 15 mg daily with gradual tapering. Occasionally, questions may ask which medication can be added onto corticosteroids for the treatment of temporal arthritis. So we can add on a low dose aspirin. Aspirin 75 mg daily has been shown to decrease the rate of visual loss and ischemic strokes in patients with temporal arthritis. So again, we can add low dose aspirin with corticosteroids or prednisolone in case of temporal arthritis or in case of giant cell arthritis. So this aspirin is given 75 mg daily, and it can decrease the rate of vision loss as well as also reduce the chances of ischemic stroke in patients suffering from this condition. So again, temporal arthritis, it is also known as giant cell arthritis. It is a type of vasculitis which is affecting the large arteries supplying eyes, optic nerves and head. New onset headache in a patient 50 years, more than 50 years of age, prompts consideration of this diagnosis. And the most dangerous or most feared complication of temporal arthritis is blindness, which can be easily prevented by early treatment with corticosteroids. Clinical features: headache in one or more temple, then scalp tenderness and jaw claudication and decreased vision. So headache, scalp tenderness, jaw claudication and reduced vision. Headache is most common feature, usually quick in onset, and scalp tenderness is comes in the form of a complaint like pain while combing hair. So that is scalp tenderness. Headache, scalp tenderness, jaw claudication and decreased vision. The patient may also have proximal stiffness in neck, shoulders, arms, hips, which is called as polymyalgia rheumatica, which may be associated with temporal arthritis. Now, investigations. Initial investigation is ESR, erythrocyte sedimentation rate, and the definitive investigation is temporal artery biopsy, which shows characteristic giant cells. The treatment should not be delayed as it can lead to permanent vision loss. So in all the patients where we are suspecting temporal arthritis, if ESR is already elevated, we have to start with corticosteroids as soon as possible, even before going for a biopsy, temporal artery biopsy. And prednisolone doses much higher in temporal arthritis as compared to polymyalgia rheumatica. In temporal arthritis, prednisolone is given 60 mg daily with gradual tapering. In polymyalgia rheumatica, it is 15 mg daily with gradual tapering. Prednisolone is given, and along with prednisolone, we can also add low dose aspirin, that is aspirin 75 mg daily, which shows reduced rate of vision loss as well as it also prevents ischemic stroke in patients suffering from temporal arthritis. So that is about temporal arthritis, and let's go through the chart here. So temporal or giant cell arthritis presentation is in the form of headache, scalp tenderness or pain during combing, transient visual field loss, age is more than 50, jaw claudication, and it is associated with polymyalgia rheumatica. Now, second investigation. In investigation, the ESR will be high, which is the best initial investigation. Definitive investigation is temporal artery biopsy. Treatment here is high dose prednisolone. We do not wait for biopsy as it can result in permanent vision loss, and low dose aspirin, that is 75 mg per day. So here is a brain trainer. A patient with headache, scalp tenderness, jaw pain presents to the emergency department. Blood tests have been sent. What is the most appropriate management? So start prednisolone. Starting prednisolone is the most appropriate medication to decrease the risk of her losing her vision. The low dose aspirin can be given in addition to prednisolone, as it can prevent myocardial infarction and stroke, and even reduce the rate of vision loss. Key learning point here is, if you are given both prednisolone and aspirin as options to choose, remember prednisolone is more important medication to start acutely. So again, giant cell temporal arteritis presentation is in the form of headache, scalp tenderness, jaw claudication, reduced vision, and scalp tenderness is in the form of pain during combing. Then age is more than 50, and it is associated with polymyalgia rheumatica. Investigation is best initial is ESR is high, most definitive is temporal artery biopsy. Treatment is with high dose prednisolone 60 mg daily. Do not wait for biopsy as delay can result in permanent vision loss. So prednisolone is started as soon as possible. Second, low dose aspirin 75 mg per day can be added, which helps in preventing myocardial infarction, stroke, as well as reduce the rate of vision loss. So here is a brain trainer. So the most appropriate management is starting prednisolone in this case, and it is the most appropriate medication to decrease the risk of her losing her vision. So corticosteroids early stage, and low dose aspirin can be given in addition, which helps to prevent MI and stroke. Key learning point is here that if prednisolone and aspirin both are given, remember prednisolone is the more important medication. Okay, so that is about temporal arteritis or giant cell arteritis. Let's study about polymyalgia rheumatica now. So polymyalgia rheumatica, it is an inflammatory condition characterized by painful and stiff neck, shoulders, upper arms, and hips. It is an inflammatory condition characterized by painful and stiff neck, upper arms, shoulders, and hips. Association with giant cell arteritis. 50% of people with giant cell arteritis have polymyalgia rheumatica. 15% of people with polymyalgia rheumatica have evidence of giant cell arteritis. So 50 and 15. Almost half of the patients suffering from giant cell arteritis have polymyalgia rheumatica, and around 15% of the people with polymyalgia rheumatica are having giant cell arteritis. Some important features to remember here are that it is found usually over 50 years of age. Shoulder, neck, upper arm, and pelvic girdle pain. The pain may start asymmetrically, but progresses to become bilateral quickly. Morning stiffness lasting more than 45 minutes, difficulty rising from a chair or raising their arms above shoulder in the morning, symptoms for 2 weeks or more, and symptoms dramatically improve with corticosteroids. ESR is more than 30 and CRP is more than 6. Now, management is by long-term prednisolone because long-term prednisolone is used for both giant cell arteritis and polymyalgia rheumatica. It is important to ensure we are managing adverse effects from steroid treatment such as cataract, osteoporosis, and gastrointestinal ulcers. So, long-term treatment with steroids can cause cataract, gastrointestinal ulcers, and osteoporosis. Now, the treatment using steroids can last for several months, so we have to ensure that we make a proper diagnosis before starting someone on steroid treatment. So, the tip to remember is we have to remember the letter P. P for polymyalgia is equals to pain, which is not weakness. Muscles are tender with no true weakness. So there is pain, not weakness in polymyalgia rheumatica. P for polymyalgia, P for pain. So there is no weakness. Muscles are tender with no true weakness. That is the tip to remember. So again, polymyalgia rheumatica. It is an inflammatory condition characterized by painful and stiff neck, upper arms, shoulder, and hip joint, hips. So now association with giant cell arteritis. 50% of the patients with giant cell arteritis are having polymyalgia rheumatica. 15% of patients with polymyalgia rheumatica are having giant cell arteritis. Some of the important features: more than 50 years of age of patients usually, then shoulder, neck, upper arm, shoulder, and hip pain or pelvic girdle pain. The pain may start asymmetrically, but it progresses to become bilateral quickly. There is morning stiffness which is lasting for more than 45 minutes, and the patient is having difficulty rising from chair, raising their arms above the shoulder level in the morning. So these patients have morning stiffness more than 45 minutes. They have difficulty rising from a chair or raising their arms above shoulder level in the morning. Symptoms are for 2 weeks or more, and symptoms dramatically improve with corticosteroids like prednisolone. ESR is more than 30, CRP is more than 6. So both are raised, ESR and CRP, as it is an inflammatory condition, and ESR is more than 30 and CRP is more than 6. Now, management is by long-term prednisolone. Usually it is given 15 mg per day with gradual tapering. We studied long-term prednisolone. Now it is, because it is used for both giant cell arteritis as well as polymyalgia rheumatica, we have to ensure that we are managing the adverse effects from steroid treatment as well. These long-term steroid treatment adverse effects are cataract, gastrointestinal ulcers, and osteoporosis. Cataract, GI ulcers, and osteoporosis. So treatment can last for several months. So we have to make sure that we make a proper diagnosis before starting someone on steroidal treatment. In polymyalgia, there is pain, but there is no weakness. There is pain and stiffness, but not weakness. That should be remembered. Anyway, let's go through the chart now. As we can see here, polymyalgia rheumatica presentation is with bilateral pain and morning stiffness of shoulders, neck, pelvic girdle. Second, difficulty in getting out of bed or raising the arms to brush the hair above the shoulder level. Third, association with giant cell arteritis, and the mean age is more than 50 years. So these are the areas of pain which we can see clearly here in the picture. It's neck, upper arms, shoulders, pelvic girdle or hip joint. Now investigation, ESR and CRP is raised. Normal creatine kinase. Treatment is with steroids, corticosteroids, oral prednisolone, and the tip here is the letter P. Polymyalgia is equal to pain, not weakness. Muscles are tender with no true weakness. There is pain and stiffness, not weakness. Here is a differential diagnosis. Myositis. In myositis, we have more weakness than pain, and in that, creatine kinase will be raised. Whereas in polymyalgia rheumatica, there is more pain than weakness, and the creatine kinase is normal. So we should remember this. So again, in polymyalgia rheumatica, presentation is bilateral pain and morning stiffness in neck, shoulder, and pelvic girdle, difficulty in getting out of bed, raising the arms to brush the hair, so above the shoulder level, association with giant cell arteritis, mean age is more than 50 years. Then investigation will include raised ESR and CRP, creatine kinase will be normal. In myositis, there is more weakness as compared to pain, and creatine kinase is raised. Whereas in polymyalgia, there is more pain than weakness, and creatine kinase is normal here. In myositis, it is not normal, there is weakness there. In myalgia, there is pain. Treatment is with steroids, corticosteroids, that is oral prednisolone given 15 mg daily with gradual tapering, and muscles are tender but no true weakness. There is pain and stiffness but not weakness here. So this is about polymyalgia rheumatica. Let's move ahead. Most initial investigation was uh, ESR, and most definitive was temporal artery biopsy in temporal arteritis or giant cell arteritis. So let's move ahead now. Now we have here a 55-year-old lady with medical history of hypertension and rheumatoid arthritis presenting with an acutely hot, swollen, tender right knee joint to the emergency department. The pain started 2 days ago. There is pain on movement. There is decreased passive and active range of motion. She reports mild fever for the past 3 days. What is the single most appropriate investigation to perform in this case? So, the presentation here is in line with septic arthritis, where rheumatoid arthritis is a risk factor. The most important diagnostic test in patients presenting with acute arthritis is examination of the synovial fluid or examination of joint aspirate. So, X-ray imaging of the joint would definitely be obtained to rule out other causes of the joint pain. However, it is not the most appropriate investigation. Plain X-rays in early disease of septic arthritis are not helpful since they will show only soft tissue swelling, and in later untreated septic arthritis, joint space narrowing and erosion will be seen, but they are not diagnostic for septic arthritis. So X-ray will show the changes, but it is not that useful for the diagnosis for septic arthritis. Ultrasound is not as sensitive as MRI or CT scan, however, it is inexpensive, can show early joint effusion, and help in guiding joint aspiration and drainage procedures. So, ultrasound can be useful. It is also inexpensive, but it is not as sensitive as MRI or CT scan. It can show early joint effusion and it can be helpful in procedures like joint aspiration and drainage procedures. CT scan and MRI are sensitive methods for diagnosing periarticular abscesses and joint effusions, but their use is reserved in cases for diagnostic difficulty, usually involving sacroiliac or sternoclavicular joint infection, where extension into the pelvis or mediastinum is a possibility. Remember that although ultrasound, CT scan, and MRI they may aid the diagnosis of septic arthritis is made on the basis of analysis of the synovial fluid or analysis of the joint aspirate on the basis of aspiration. So here the presentation is of septic arthritis, where rheumatoid arthritis is a risk factor. And the most important diagnostic test in patients who are presenting with acute arthritis is examination of the synovial fluid, examination of joint aspirate. Talking about X-ray imaging would be obtained and it can be helpful in ruling out other causes of joint pain, but it is not the most appropriate investigation. Even in case of septic arthritis, these plain X-rays would only show soft tissue swelling in the early stages. And in later untreated cases of septic arthritis, they may show erosion, they may show joint space narrowing, but these are not useful in diagnosis for septic arthritis. Ultrasound, not as sensitive as MRI or CT, but can be useful, also inexpensive, useful in procedures like drainage as well as joint aspiration. CT scan, MRI, very sensitive methods used for diagnosing periarticular abscesses and joint effusions, but their use is reserved for the case of diagnostic difficulty, usually involving sacroiliac or sternoclavicular joint infection, where extension into the pelvis or into the mediastinum is a possibility. So we have to remember, although these all scanning methods like ultrasound, MRI, CT, these are useful in the diagnosis, they may help in the diagnosis, but the diagnosis of septic arthritis is made on the basis of aspiration or examination of synovial fluid or joint aspirate. Let's study about septic arthritis a little more. Let's see if we have a chart on this. Septic arthritis. Anyway, yes, so talking about septic arthritis, the two most common organisms which cause septic arthritis are Staphylococcus aureus and Neisseria gonorrhoeae. So, Staphylococcus aureus and Neisseria gonorrhoeae. Staphylococcus aureus is the most common pathogen for septic arthritis overall. Second, Neisseria gonorrhoeae, it is seen in young sexually active adults. Most cases of septic arthritis are due to hematogenous spread during transient bacteremia, but can also be introduced by a skin lesion which penetrates a joint or by local spread from a contagious infected site. Now, the risk factors. Prior joint damage, that is by rheumatoid arthritis, gout, osteoarthritis. It is particularly important to remember rheumatoid arthritis is a risk factor as it is commonly asked in septic arthritis. It is a common risk factor. Second, immunodeficiency state like HIV or use of corticosteroids. Third is diabetes. Now, so risk factors are prior joint damage by rheumatoid arthritis, gout or osteoarthritis, or second immunodeficiency state like HIV or taking corticosteroids, third diabetes. Presentation is single swollen red joint with pain on active or passive movement. Second, restricted joint movements. Third, fever and rigors. Fourth, knee is involved in more than 50% of the cases. So remember the triad of fever, pain, and impaired range of motion. Fever, pain, and impaired range of motion. This is a triad of septic arthritis. So we have single swollen red joint with pain on active or passive movement. There are restricted joint movements, fever and rigors are there, and knee is involved in more than 50% of the cases. And we have to remember a triad of fever, pain, and impaired range of motion or immobility or difficulty in motion, active or passive movements. Now, investigations. First is the aspiration of synovial fluid, which is sent for gram staining, leukocyte count, microscopy, and culture, which is a good pick if the question is asking for the single most appropriate investigation for an acute, hot, swollen, painful joint. Aspiration of synovial fluid, which is sent for gram staining, leukocyte count, microscopy, and culture. Microscopy and culture, and gram staining and leukocyte count. Second is blood culture. Remember, most cases of septic arthritis are due to hematogenous spread. So, blood culture is also useful here because we already studied most cases of septic arthritis are due to hematogenous spread during transient bacteremia, which can be introduced by a skin lesion penetrating joint or by local spread from a contagious infected site. So, for investigation, aspiration of synovial fluid and blood culture. Management is by flucloxacillin for 4 to 6 weeks. If penicillin allergic, then use clindamycin. If gonococcal arthritis, use cefotaxime or ceftriaxone. If infection is not responding to antibiotics, then we perform repeated percutaneous aspiration. In general, IV antibiotics are used for 7 days until the swelling subsides and blood cultures become negative. This is followed by a 4-week course of oral antibiotics. So, in general, IV antibiotics are used for 7 days until the swelling subsides and blood culture become negative, and it is then followed by a 4-week course of oral antibiotics. So that is about septic arthritis. So again, the two most common organisms which are responsible for causing septic arthritis are Staphylococcus aureus and Neisseria gonorrhea. Staphylococcus aureus is the most common pathogen for causing septic arthritis overall. Neisseria gonorrhea is more commonly seen in young sexually active adults. Now, most of the cases of septic arthritis are caused due to hematogenous spread during transient bacteremia, which can be, but it can also be introduced by a skin lesion. So most of the times, the septic arthritis is caused due to hematogenous spread during transient bacteremia, but it can also occur by a skin lesion which penetrates the joint or by local spread from a contagious infected site. So there are different methods by which it can spread. Hematogenous spread introduced by skin lesion which penetrates the joint or by local spread from a contagious infected site. Now risk factors of septic arthritis are prior joint damage by rheumatoid arthritis, gout, osteoarthritis. Second, immunodeficiency state like HIV or on corticosteroid treatment. And third, diabetes. These are three risk factors for septic arthritis. Apart from this, presentation. Now, presentation, we will have single swollen red joint with pain on active or passive movement. So we will have single red swollen joint with pain on active or passive movement. So there will be restricted joint movement and there will be fever and rigor, and we have to remember that knee joint is involved in more than 50% of the cases of septic arthritis. So we have to remember a triad of fever, pain, and restricted mobility or restricted movement of joint or impaired range of motion. So we have to remember this triad in septic arthritis: fever, pain, and restricted movement, or fever, pain, and impaired movement, impaired range of motion. So single swollen red joint with pain on active or passive movement, restricted joint movement, fever and rigors, knees involved in more than 50% of the cases. Now, investigation is by aspiration of synovial fluid and blood culture. Most important is aspiration of synovial fluid. This fluid, this aspirate, joint aspirate is sent for gram staining, microscopy, culture, and leukocyte count. It is an important investigation for an acute, hot, swollen, painful joint. Most appropriate investigation. Blood culture, because we studied it, it can spread by hematogenous method or hematogenous spread. Septic arthritis, most of the cases are due to hematogenous spread. Now, coming to management of septic arthritis. Management is by flucloxacillin for 4 to 6 weeks. That is a type of antibiotic which is being used here. Now, flucloxacillin for 4 to 6 weeks. If the patient is allergic to penicillins, then we use clindamycin. Now, if it is a gonococcal arthritis, then we will use ceftriaxone or cefotaxime. Now, if the infection is not responding to antibiotics, then we will perform repeated percutaneous aspiration. So, flucloxacillin for 4 to 6 weeks. If penicillin allergic to penicillin, then clindamycin. If gonococcal arthritis, then use cefotaxime or ceftriaxone. And if infection is not responding to antibiotics, then repeat percutaneous aspiration. In general, IV antibiotics are used for 7 days when the swelling subsides and blood culture becomes negative. This is then followed by around 4 weeks of oral antibiotics. So IV antibiotics for 7 days until the swelling subsides and blood culture becomes negative, followed by 4-week course of oral antibiotics. So this is about septic arthritis. Now, now here we have a 49-year-old woman with medical history of diabetes and rheumatoid arthritis presenting with left knee pain which has been worsening over the last 24 hours. There is no history of trauma to the knee. She has fever and rigors. On examination, there is decreased range of movement and the left knee joint is red and edematous. Septic arthritis is suspected. What is the single most common organism responsible for septic arthritis? So we have both Staphylococcus aureus and Neisseria gonorrhoeae in the options. But we know Staphylococcus aureus is the most common organism, most common bacteria causing septic arthritis, infecting adult joints. Staphylococcus aureus SA, septic arthritis SA. It can be used to remember like that. Flucloxacillin, if resistant to flucloxacillin, if resistant to penicillin, then clindamycin. Then if gonococcal arthritis, we use ceftriaxone or cefotaxime. Flucloxacillin for 4 to 6 weeks, and IV antibiotics given for 7 days, followed by 4 weeks of oral antibiotics till the blood culture becomes negative and swelling subsides. If the patient is not responding to antibiotics, then we will perform repeated percutaneous aspiration. Okay, so now let's take a break and I'll be back. So now let's move ahead. Now we have a 70-year-old man attending the GP surgery with pain in his left knee. The pain started around 3 days ago, associated with knee swelling and redness. He has no history of any injury to the knee. The symptoms are accompanied by malaise. The joint is extremely tender with overlying erythema. His medical history includes systolic heart failure, ankle edema, and Raynaud's syndrome. He takes regular losartan, bisoprolol, nifedipine, digoxin, and indapamide. Which medication is likely to have contributed to these symptoms of knee pain? So the diagnosis here is acute gout of the left knee, which can be precipitated by thiazide-like diuretics like indapamide. So we should know here that indapamide is a kind of thiazide diuretic. It is a thiazide-like diuretic, which is used to treat hypertension. Indapamide can cause gout. So, as we studied, FACT plus the drugs which cause gout are FACT plus niacin. FACT stands for furosemide, then alcohol, then cytotoxic drugs or cyclosporine, chemotherapy, then thiazide diuretics or thiazide-like diuretics, such as thiazide diuretics and thiazide-like diuretics. Example are bendroflumethiazide, bendroflumethiazide, and indapamide. Thiazide diuretic example bendroflumethiazide, and thiazide-like diuretic indapamide. All these are responsible for causing gout. FACT plus niacin, furosemide, alcohol, cytotoxic drugs, cyclosporin, then thiazide diuretics and thiazide-like diuretics, thiazide diuretics bendroflumethiazide, and thiazide-like diuretic indapamide. Let's move ahead. Now, a 27-year-old female complains of intermittent pain in her fingers, usually brought about in cold weather. She describes episodes of numbness and burning of the fingers. Her fingers usually become very pale if she does not wear gloves when going outdoors. What is the single most likely diagnosis here? So, this is an example of Raynaud's phenomenon. Now, let's study about Raynaud's phenomena. Raynaud's phenomena is defined as episodes of pallor or cyanosis in response to cold or emotional stimuli. Raynaud's phenomena is defined as episodes of pallor or cyanosis in response to cold or emotional stimuli. Fingers or toes ache and change color. That is the thing which happens here. Pale ischemia, blue deoxygenation, and red reactive hyperemia. So the fingers and toes, they start to ache and they change color. They can become pale due to ischemia. They can become blue due to deoxygenation. They can become red due to reactive hyperemia. The pallor is caused by vasoconstriction of blood vessels, that is arteries and arterioles, which results in reduced blood flow, whereas cyanosis is created by deoxygenation of slow flowing blood. After rewarming the hands, blood flow will rebound, hyperemia, and the skin will appear reddened or blushed. So after rewarming the hands, the blood flow will rebound, will restore, causing hyperemia, and the skin will appear reddened or blushed. It is common for patients with Raynaud's phenomena to complain of cold sensitivity or to have other areas of the skin involved, such as ears, nose, lower extremities, etc. So episodes come. So it is common for the patients with Raynaud's phenomena to complain of cold sensitivity and to have other areas of the skin involved, like ears, nose, and lower extremities. Ears, nose, and lower extremities. Now, episodes come as sudden attacks, and these are most often triggered by rapid changes in ambient temperature. Attacks may begin in one or two fingers, but typically they involve all fingers and toes symmetrically and bilaterally. Okay, so hmm. So talking about this Raynaud's phenomena. So, as we studied, these episodes may come as sudden attacks, and these are most often triggered by rapid change in ambient temperature. Attacks may begin in one or two fingers, but typically they may involve all the fingers and toes symmetrically and bilaterally. Primary Raynaud's phenomena or Raynaud's disease denotes a patient without an associated underlying disease, whereas secondary Raynaud's phenomena is used to describe patients with a defined secondary or associated disease like scleroderma. So primary Raynaud's without underlying cause, secondary in associated conditions like scleroderma, and we treat with nifedipine. In secondary Raynaud's phenomena, symptoms may first begin in just one or two fingers on one hand. This is in contrast to primary Raynaud's phenomena, when all the fingers on both the hands are typically affected. So again, Raynaud's phenomena is defined as episodes of pallor or cyanosis in response to stimuli like cold or emotional stimuli. So Raynaud's phenomena is defined as episodes of pallor or cyanosis in response to cold or emotional stimuli, cold stimulus or emotional stimulus. The fingers in this Raynaud's phenomena, fingers or toes, they may start to ache and they may change color. They can become pale Due to ischemia, they can become bluish. Blue due to deoxygenation, they can become red due to reactive hyperemia. Now, the pallor is caused by vasoconstriction of blood vessels, that is arteries and arterioles, resulting in reduced blood flow, whereas cyanosis is caused by deoxygenation of the slow flowing blood, whereas due to rewarming of the hands, after rewarming the hands, blood flow will restore, will rebound, and it leads to hyperemia, and the skin will appear reddened or blushed. It is common for the patients with Raynaud's phenomena to complain of cold sensitivity and to have other areas of the skin involved as well, for example, nose, ear, and lower extremities. These episodes may come as sudden attacks, and these are most often triggered by rapid changes in ambient temperature. The attacks may begin in one or two fingers initially, but typically they involve all fingers or toes symmetrically and bilaterally. So they may begin in one or two fingers, but typically uh, in Raynaud's phenomena, in mainly in primary Raynaud's phenomena, they involve all fingers or toes symmetrically and bilaterally. Primary Raynaud's phenomena or Raynaud's disease occurs in a patient without an associated underlying disease, whereas secondary Raynaud's phenomena, it is used to describe patients with a defined secondary or underlying or associated condition like scleroderma. We use nifedipine for treatment, and in primary Raynaud's phenomena, symptoms usually involve all the fingers on both the hands typically, whereas in secondary they may start with one or two fingers on one hand. So that is the difference. Okay, now let's move ahead. A 33-year-old woman presenting with muscle and joint pain and fatigue over the past year. She also gives a history of losing hair. On examination, a purplish rash is seen on the bridge of the nose and cheeks, sparing the nasolabial folds. A urine analysis was checked and was positive for proteinuria and hematuria. What is the single most appropriate initial investigation in this case? So here we will study about SLE, that is systemic lupus erythematosus. All the tests above may be ordered when investigating for SLE, like complement levels, anti-double-stranded DNA, anti-nuclear antibodies, anti-histone, anti-Smith. However, anti-nuclear antibody, that is ANA, is the most sensitive of all the tests in all these options which are given, and it is usually ordered alongside full blood count, LFTs, UNE, ESR, and CRP while suspecting SLE. Now, anti-double stranded DNA may be more specific, these antibodies, but it is less sensitive compared to ANA. As this question is asking for initial investigation, so ANA would be more appropriate as it is more sensitive. And alopecia is a common phenomenon in SLE. So in SLE, for most initial appropriate investigation and most sensitive investigation, we have to choose ANA, that is anti-nuclear antibodies, whereas most diagnostic specific or the single best test or the most appropriate, because it is more specific than even ANA. That would be anti double stranded DNA, anti dsDNA, anti double stranded DNA. That would be the most appropriate diagnostic test, most specific, and single best test, the most appropriate anti ds DNA, anti double stranded DNA for SLE. Now let's study about SLE. So SLE or systemic lupus erythematosus, the important features are: first, limiting and relapsing illness; second, mouth ulcers, which are large, multiple, and painful; third, lymphadenopathy; fourth, malar or butterfly rash, sparing nasolabial folds; fifth, discoid rash, which is scaly erythematous, well demarcated rash in sun exposed areas; then sixth, photosensitivity; seventh, arthralgia, which in this arthritis and arthralgia frequently involve the wrist and small joints of the hands. Then seventh, Raynaud's phenomena, which is occurring about one-fifth of the patient but is mild. Eighth, cardiovascular manifestation like pericarditis. Then ninth, respiratory features like pleurisy and fibrosing alveolitis. Pleurisy and fibrosing alveolitis. And for renal, we will have glomerulonephritis, which is often symptomatic, is detected by proteinuria, hematuria, and hypertension or a raised serum urea or creatinine. Now, neuropsychiatric symptoms would be anxiety and depression. Now, the investigations will be full blood count and ESR. Here we will see raised ESR, and in full blood count we will see mild normochromic normocytic anemia. Mild normochromic normocytic anemia in SLE. And ESR is raised. Then autoantibodies which we see are anti-nuclear antibody ANA. It is a screening test with a sensitivity of 95% but not diagnostic in the absence of clinical features. It is a non-specific antibody which is also present in many patients with systemic autoimmune conditions. So it is not that specific, but it is highly sensitive because it is also present in other systemic autoimmune conditions. Then anti-dsDNA, anti-double stranded DNA, which is highly specific of SLE, more than 99%, but it is less sensitive. Then anti-Smith, which is highly specific, again more than 99%, but even less sensitive, 30 to 40%. Anti-Stone, drug-induced lupus ANA antibodies are often this type. Drug-induced lupus ANA antibodies, these are of this type, anti-Stone. Then 20% are rheumatoid factor positive. Complement levels C3 and C4 are low during active disease where there is formation of complexes leading to consumption of complements. So during active disease, complement levels C3 and C4 are low because formation of complexes leads to consumption of complements. The tip to remember is pick ANA if the question is asking for most sensitive test, most initial test, or the best screening test. Then we have to pick ANA, anti-nuclear antibody, and pick anti-double stranded DNA if the question is asking for most specific test or most discriminative test. Most specific and most discriminative, that would be anti-double stranded DNA. Usually anti-Smith antibody is not given as an option. So again, SLE or systemic lupus erythematosus, the important features are: first, it has remitting or relapsing illness. It is a remitting or relapsing illness. Then there are mouth ulcers, which are large, multiple, and painful. There is lymphadenopathy. There is malar or butterfly rash, which is a sparing nasolabial folds. Then there is discoid rash, which is scaly erythematous, well demarcated rash, which is found in sun exposed areas, discoid rash. Then there is photosensitivity, and there is arthralgia, arthritis and arthralgia, which are involving the wrist joints and small joints of the hands. And there is Raynaud's phenomena occurring about 1/5 of the patient, but mild. Then cardiovascular manifestations like pericarditis, respiratory manifestation like pleurisy and fibrosing alveolitis, and renal manifestations like glomerulonephritis, which is often symptomatic and detected by proteinuria, hematuria, hypertension, and raise serum urea level or creatinine level. Neuropsychiatric symptoms like anxiety and depression. Investigations would be: first, ESR and full blood count. ESR would be raised. In full blood count, we will see mild normocytic normochromic anemia, mild normochromic normocytic anemia, and ESR would be raised. And then we will detect autoantibodies. Autoantibodies first, ANA, anti-nuclear antibodies, screening tests which are highly sensitive, having a sensitivity of 95%, but they are not diagnostic in the absence of clinical features, because these are non-specific antibodies also found or also present in other systemic autoimmune conditions. Whereas anti-double stranded DNA, these are highly specific but less sensitive. Highly specific more than 99%, less sensitive around 70%. Then anti-Smith, these are also highly specific, more than 99%, but even less sensitive, 30 to 40%. Anti-histone, drug-induced lupus AN antibodies are of this type. 20% are rheumatoid factor positive. Complement levels C3 and C4 are low during the active disease because the formation of complexes lead to consumption of these complements. Now the tip or the takeaway point here is we have to pick ANA, anti-nuclear antibody, if they are asking for most initial test, most initial investigation, or most sensitive test, or best screening test. Most appropriate initial test or most sensitive test or best screening test, then ANA. But if they are asking for most specific test or most discriminative test, like the best test to diagnose SLE, that would be anti-double stranded DNA. If they are asking for most specific or most discriminative or most appropriate, then that answer would be anti-double stranded DNA. In that case, not ANA. ANA is more sensitive, most initial, best for screening, and anti-double stranded DNA is most specific and most discriminative. Now let's go through the chart here. So here we can see SLE, systemic lupus erythematosus. It is an autoimmune disorder with multi-organ involvement. General presentation is fatigue, fever, mouth ulcers. In skin, we will see malar butterfly rash on the face, photosensitivity, discoid rash on sun exposed areas, then Raynaud's phenomena. Joints, we will see arthralgia and peripheral and symmetrical polyarthritis. Cardiovascular, we'll see pericarditis, Liebman-Sachs endocarditis. Then respiratory, we will see pleuritis. And in renal symptoms, we will see glomerulonephritis. Most common is diffuse proliferative. And this is a picture representing SLE here. Uh, Here we can see in systemic we will have low grade fever, photosensitivity. In mouth and nose we will see ulcers. In muscles there will be ache, pain, and in joints we will see arthritis. Psychological, we will see fatigue and loss of appetite. Fatigue and loss of appetite. Face, we will see butterfly rash, despairing nasolabial fold. Then in pleura we'll see inflammation. Pericardium we'll see inflammation. Kidneys we'll see inflammation. Fingers and toes, there will be poor circulation. For investigation, ANA will have a high sensitivity, and anti-double stranded DNA antibody, they will have high specificity. C3 C4 complement levels would be low. Antihistone, drug induced SLE, in case of drug induced SLE, antihistone antibodies will be detected. In case of drug induced SLE, antihistone antibodies. Now treatment or management is by hydroxychloroquine. In case of skin lesions, arthralgia, myalgia, and oral ulcers, it will help in hydroxychloroquine. Help in skin lesions, arthralgia, myalgia, and oral ulcers. Then NSAIDs, which will help in arthralgia and myalgia. Prednisolone is used in severe cases, and cyclophosphamide is used in life-threatening lupus nephritis and vasculitis. In drug-induced lupus, we will use hydralazine, chlorpromazine, and isoniazid. So again, for management, hydroxychloroquine for skin lesion, arthralgia, myalgia, and oral ulcers, NSAIDs for arthralgia and myalgia, prednisolone for severe cases, cyclophosphamide for life-threatening lupus nephritis and vasculitis. So hydroxychloroquine, NSAIDs, prednisolone, and cyclophosphamide. Whereas in case of drug-induced lupus, drug-induced SLE, we will use hydralazine, chlorpromazide, and isoniazid. Now, a 44-year-old and all the other features sounding like lupus, what is the most sensitive test? Or what is the most initial test? What is the best screening test? That is ANA, anti-nuclear antibody. If they're asking what is the most specific test, what is the most discriminative test, best investigation, that would be anti-double stranded DNA. So this is about SLE, systemic lupus erythematosus. Systemic lupus erythematosus, which is an autoimmune disorder with multi-organ involvement. General features would be fever, fatigue, mouth ulcers in skin, butterfly rash or malar rash on face, then photosensitivity on sun exposed areas, discoid rash on sun exposed areas, and Raynaud's phenomena. In joints, we will see arthralgia and polyarthritis. Arthralgia and polyarthritis. In cardiovascular, we will see pericarditis and Liebman-Sachs endocarditis. In respiratory, we will see pleuritis And in renal symptoms, renal manifestation, we will see glomerulonephritis, and mainly we will see diffuse proliferative type of glomerulonephritis. Here we have a whole picture representing SLE. We can see systemic features are low grade fever, photosensitivity, and mouth and nose. We will see ulcers, muscles, aches, joints, arthritis, psychological fatigue, and loss of appetite, face butterfly rash, and pleura inflammation, pleuritis, and pericardium inflammation, pericarditis. In kidneys also we will see inflammation, that is glomerulonephritis, and in fingers and toes we will see poor circulation. In fingers and nose, in fingers and toes, we will see poor circulation. Now coming on to investigations, ANA will have high sensitivity. ANA will have high sensitivity, and anti-double stranded antibody will have high specificity. C3, C4 complement levels would be low. Antihistone will be found in case of drug-induced SLE. Management is by hydroxychloroquine, then prednisolone, NSAIDs, and cyclophosphamide. Management of SLE is by hydroxychloroquine given in skin lesions, arthralgia, myalgia, and oral ulcers, NSAIDs for arthralgia, myalgia, and prednisolone for severe cases, cyclophosphamide in case of life-threatening nephritis and vasculitis. So hydroxychloroquine, NSAIDs, prednisolone, and cyclophosphamide. Whereas in case of drug-induced SLE, we will give hydralazine, chlorpromazine, and isoniazid. Hydralazine, chlorpromazine, and isoniazid. In case of drug-induced SLE, we will give hydralazine, chlorpromazine, and isoniazid. What is the most sensitive test or most initial test or the best screening test? That is ANA, anti-nuclear antibodies, which is most initial test and most sensitive test and best screening test, whereas most specific test and most discriminative test, best diagnostic method, that would be anti-double stranded antibodies, anti-double stranded DNA antibodies. Okay, let's move ahead now. A 39-year-old man has been coughing up specks of blood for the past 4 weeks. He has been feeling fatigued over the past 4 months. He has been suffering with pain around his sinuses with nasal obstruction over the past 2 years. Occasionally, he has bloody rhinorrhea. He has a saddle nose deformity, and there are subcutaneous nodules on his elbows. Now, what is the single most likely diagnosis? So again, a 39-year-old man has been coughing up specks of blood for the past 4 weeks, has been feeling fatigued over the past 4 months, suffering with pain around his sinuses, with nasal obstruction of the past 2 years, has bloody rhinorrhea, saddle nose deformity. There are subcutaneous nodules on his elbows. So they are asking about the single most likely diagnosis in this case. So this is a case of granulomatosis with polyangiitis, previously known as Wegener's granulomatosis. So the patient has granulomatosis with polyangiitis, previously known as Wegener's granulomatosis, Chronic sinusitis with bloody rhinorrhea are typical. In this chronic sinusitis with bloody rhinorrhea, these are typical. There is usually a respiratory component too, which involves bleeding into the lungs, causing the patient to cough up blood. The saddle nose deformity is characteristic and is due to a hole in the septum of the nose. The skin can also be involved and it may present as purpura or even subcutaneous nodules on the elbow. So this is Wegener's granulomatosis or granulomatosis with polyangiitis. We can remember like in good pastures disease, patient is coughing and peeing blood. Whereas here the patient is not just coughing, patient is also bleeding from the nose. In Wegener's granulomatosis, patient is also bleeding from the nose. Bloody rhinorrhea, which is typical. Chronic sinusitis with bloody rhinorrhea. This is a typical feature of Wegener's granulomatosis or granulomatosis with polyangiitis, which is chronic sinusitis with bloody rhinorrhea. Let's study more about this granulomatosis with polyangiitis. See if we have a chart on this. Now, granulomatosis with polyangiitis. Granulomatosis with polyangiitis, previously known as Wegener's granulomatosis, is an idiopathic small to medium vessel vasculitis which appears around middle age. It is an idiopathic small to medium vessel vasculitis appearing around middle age. This granulomatosis with polyangiitis can present with a host of signs and symptoms, but we have to look for anything affecting the upper respiratory tract, lungs, and kidneys. That we should remember. In the exam, we should look for anything which is affecting upper respiratory tract, lungs, and kidneys. In the long questions such as this, we have to be able to pick out the keywords. So, upper respiratory tract, we will see nosebleeds, crust around nostrils, chronic sinusitis, saddle nose deformity, bloody rhinorrhea. Those are the keywords here. For upper respiratory tract, we will have nosebleeds, chronic sinusitis, crust around nostrils, saddle nose deformity, bloody rhinorrhea. For lungs, we will see hemoptysis and cough. Hemoptysis and cough. For kidneys, we will see hematuria and kidneys. So we have to try to imagine a person who is bleeding from his nose, lungs, and kidneys. A person bleeding from his nose, lungs, and kidneys. Person who is bleeding from his nose, lungs, and kidneys. Whereas in good pasture, it was cough and through kidneys. Lungs and kidneys in good pasture. Here it is through along with lungs and kidney, there is also nose here. Remember that CANCA, that is anti-neutrophil cytoplasmic antibodies, usually test positive in granulomatosis with polyangiitis, whereas PANCA, these are usually seen in eosinophilic granulomatosis with polyangiitis, that is Churg-Strauss syndrome. So here we have CANCA, and in eosinophilic granulomatosis with polyangiitis or Churg-Strauss syndrome, there we will see PANCA. The treatment of granulomatosis with polyangiitis is beyond the scope of this exam. so we'll not be going into the detail there. So let's see it again. Granulomatosis with polyangiitis, previously known as Wegener's granulomatosis. It is an idiopathic small to medium vessel vasculitis which appears around the middle age. Idiopathic small to medium vessel vasculitis appearing around middle age. It can present with a host of signs and symptoms, mainly affecting nose, lungs, and kidneys. Just remember like that: nose, lungs, and kidneys. Or we can remember like upper respiratory tract, lungs, and kidneys. Signs and symptoms are listed like that: upper respiratory tract, lungs, and kidneys. So, in upper respiratory tract, we will have nosebleeds and chronic sinusitis, bloody rhinorrhea, and saddle nose deformity. So, nosebleeds, saddle nose deformity, bloody rhinorrhea, and chronic sinusitis. So, this is in upper respiratory tract. Whereas in lungs, we will have cough and hemoptysis, and in kidneys, we will have hematuria. So, in upper respiratory tract, nosebleeds, saddle nose deformity, bloody rhinorrhea, and chronic sinusitis. In lungs, cough and hemoptysis. In kidneys, hematuria. So, the patient is bleeding from nose, lungs, and kidneys. Okay, so we have to remember that in case of Churg-Strauss syndrome or eosinophilic granulomatosis with polyangiitis, PANCA is positive, whereas here in case of granulomatosis with polyangiitis or Wegener's granulomatosis, CANCA is positive here. Okay, now let's go through the chart. Now here we can see granulomatosis with polyangiitis or Wegener's granulomatosis. First, upper respiratory tract. Here we already studied nose bleeding. Okay, nose bleeding can be there, bloody rhinorrhea, and chronic sinusitis, saddle nose deformity. So here we can see nasal perforation, chronic sinusitis, epistaxis, and lower respiratory tract. We are seeing hemoptysis, dyspnea, and in renal we are seeing hematuria due to glomerulonephritis. Now investigations: CANCA, RBC casts in urine, and biopsy or affected site. Treatment is usually not asked. So we have to look for keywords in a patient who has hemoptysis. Some keywords are saddle shaped nose, crusting around nose, subcutaneous nodules on the elbow. Mnemonic for investigations is World Cup, Wegener's granulomatosis, CANCA. So we already studied that we have to remember, we have to imagine a patient who is bleeding from nose, lungs, and kidneys. And for signs and symptoms or manifestations, we can remember it like upper respiratory tract, lungs, and kidneys. Upper respiratory tract, we will see nosebleeds, bloody rhinorrhea, saddle nose deformity, chronic sinusitis, and crushed around nostrils. Crushed around nostrils is also important. In lungs, we will see cough, hemoptysis, dyspnea, difficulty in breathing, cough, hemoptysis, and dyspnea. In kidneys, we will see hematuria due to glomerulonephritis. And further, if we'll see for investigations, CANCA positive. and RBC casts in the urine, and biopsy of affected cells, affected site. Treatment is usually not asked, and for keywords, certain keywords would be saddle nose deformity or saddle shaped nose, crusting around nostrils, or subcutaneous nodules on the elbow. Subcutaneous nodules on the elbow, CA and CA positive. Okay, let's move ahead now. We already saw that the skin can also be involved, and it may present as purpura or even subcutaneous nodules on the elbow. This we have to remember, that in granulomatosis with polyangiitis or Wegener's granulomatosis, skin can also be involved and it may present as purpura or subcutaneous nodules on the elbow. Okay, now let's move ahead. A 34-year-old woman has intermittent pain in her fingers, usually brought about in cold weather. The colors of her fingers change when she is exposed to cold. First, it turns pale. After a few hours, it becomes blue, then red with burning sensation before returning to a normal color. What is the single most appropriate drug to prescribe which would benefit her symptoms? So we can see here she is suffering from Raynaud's phenomena, and nifedipine is the only licensed drug in the UK for the management of Raynaud's phenomena. Amlodipine is also a calcium channel like nifedipine, but it is not licensed for Raynaud's phenomena in the UK. So we will not take amlodipine even if it is given, even though it is also a calcium channel blocker just like nifedipine, but because it is not licensed for use in the UK, so we will go with nifedipine as the answer in Raynaud's phenomenon, not amlodipine. So this patient is suffering from Raynaud's phenomena, and nifedipine is the only licensed drug in the UK for the management of Raynaud's phenomena, not amlodipine, which is also a calcium channel blocker but not licensed. Okay. And Raynaud's phenomena can be seen in Sjogren's syndrome, SLE, and scleroderma as per rheumatology. So it can be seen in scleroderma, it can be seen in SLE, and it can also be seen in Sjogren's syndrome, Raynaud's phenomena. Nifedipine is used in Raynaud's phenomena. Nimodipine is used in subarachnoid hemorrhage to prevent reflex vasospasm. Amlodipine is used in hypertension in whites more than 55 years in Afro. So nifedipine used in Raynaud's phenomena. Nimodipine used in subarachnoid hemorrhage to prevent reflex vasospasm. And amlodipine is used in management of hypertension in whites more than 55 years. And Afro. Let's move ahead now. Now we have a 25-year-old woman presenting with easy fatigability, even with a little exertion. She complains of headaches, which comes and goes. She finds it difficult to sleep, feeling body aches everywhere. She describes feeling tired throughout the day with difficulty in concentrating. She has no previous medical conditions of note. Her symptoms have been persistent for the past 6 months. She remembers the symptoms started after a viral infection which gradually worsened over time. Blood tests like full blood count, urea, electrolytes, liver function tests, thyroid function tests, C reactive protein, random blood glucose, creatine kinase, and urine analysis have returned with normal ranges. What is the single most likely diagnosis in this case? So this is a case of chronic fatigue syndrome. So chronic fatigue syndrome, it is a clinical syndrome involving severe fatigue unrelated to exertion or triggered by minimal activity and unrelieved by rest. Features are persistent or recurrent fatigue, fatigue unexplained by other conditions, difficulty in sleeping, muscle and joint pain at multiple sites without any evidence of inflammation, painful lymph nodes without pathological enlargement, headaches, then cognitive dysfunction such as difficulty in thinking, concentrating, or finding words. Sometimes patient may link their symptoms onset to the start of a viral infection. They remember the precise beginning as it appeared together with a viral infection with sore throat, fever, tender lymph nodes, but had continued for months. Before labeling the patient with chronic fatigue syndrome, we have to be sure to investigate for further autoimmune rheumatic diseases which cause pain and fatigue. Other differentials here can be polymyalgia rheumatica as well, but we already studied about that. There should be elevated ESR, CRP, clinical presentation to make the diagnosis. Typically, it affects patients who are 65 plus, and patient may also develop temporal arthritis in that case. And talking again about chronic fatigue syndrome, it is a clinical syndrome involving severe fatigue and it is unrelated to exertion or triggered by minimal activity and it is not relieved by rest. Features are persistent or recurrent fatigue, fatigue which is unexplained by other conditions, difficulty in sleeping, and muscle and joint pain at multiple sites without any evidence of inflammation, painful lymph nodes without any pathological enlargement, headaches, and cognitive dysfunction as well, like difficulty in concentrating, difficulty in thinking or finding words. Sometimes patient may link these symptoms to an onset of a viral infection, and that those symptoms just continued for months after that. But we have to be very attentive before diagnosing a patient with chronic fatigue syndrome. Before labeling the patient with this, we have to be sure to investigate for other autoimmune rheumatic diseases which are responsible for causing pain and fatigue. Autoimmune rheumatic diseases. Okay, so this was about chronic fatigue syndrome. Let's move ahead. Now, a 45-year-old woman complains of pain in her hands precipitated by exposure to the cold weather. She also has breathlessness on walking. When she eats, she can feel food sticking to her throat. She finds it difficult to swallow. It is usually relieved with a drink of water. What is the single most likely cause of her dysphagia in this case? So, from here, we will continue in the next session, and I'll be back.